I'm pleased to introduce Dr. Mukadam, who hopefully is going to make her way to the lectern. Dr. Mukadam, she's a psychiatrist who carried out research looking at dementia in people from a South Asian background, and she now researches risk factors for dementia with a particular interest in how risk factors vary in different countries, and therefore presumably cultures and demographics. So thank you very much.
Thanks for the introduction, and thanks for having me, BNPA. Rob is always a very hard act to follow, so I'll do my best. But in a way, it's sort of the opposite spectrum, isn't it, from treatments to prevention. So I think we're all interested in whether we can prevent dementia. I think there's been growing interest in this. Just some acknowledgement, some funding for the work that I'll present here, as well as co-authors. So just as a bit of background, I'm an old age psychiatrist as well, and a researcher at UCL, and I've been part of the Lancet Commissions for Dementia Prevention, Intervention and Care, which have been published in 2017 and 2020. And as part of that, I did the work on calculating population attributable fraction. So sort of became aware of this growing literature from the past few decades of this idea of potentially modifiable risk factors for dementia. So there's been a shift in our understanding of dementia as something that was inevitable and, as a result of aging, to something that maybe we could do something about. But in this talk, I'll present some of the evidence about the potentially modifiable risk factors, but then I'll also go on to talk about really how practical is it, what would it cost to try and prevent dementia, and also we'll be talking a little bit about equality and diversity, as that's another area of my interest. So I'll first present work about the costs and benefits of targeting risk factors, and then I'll look at how the setting that you're looking at affects prevention efforts, and also variations within countries. So some of you may have seen this picture. This is from the Lancet Commission 2020. So in Lancet Commission 2017, there was a sort of, the headline news was up to 35% of dementia cases may be preventable, and then that went up slightly in 2020 to up to 40% of dementia cases may be preventable. And essentially what we did to work this out was we had a sort of group of international experts. There was a lot of debate about what risk factors to include, and in general, we wanted risk factors that basically met criteria for potential causality. So they had to be robust evidence, multiple studies, ideally systematic reviews and meta-analyses. There needed to be basically meeting all criteria for causality in terms of temporality, dose response, and so on. And then this is the result of all of those. And in the 2021, we added the three risk factors that we added were excess alcohol, traumatic brain injury, and air pollution. So the population attributable fraction is essentially, it's a theoretical statistical concept. The idea being that what percentage of a disease is potentially preventable if you eliminate a risk factor. So already you can see that, well, actually for many of these, you're not going to eliminate them, but it's, as I said, it's a theoretical construct that just sort of gives us a magnitude of effect, as it were. And it's calculated based on how common the risk factor is. So the more common it is, the more of an impact it has on the disease in question, in this case, dementia. And then the relative risk. So the bigger the relative risk, the more of an impact it has. So you can see at the beginning, we sort of group these into early life, midlife, and late life. Somewhat arbitrary because actually something like smoking, for example, we assume has an effect throughout life, but most of the studies happen to be studying people in later life. So that's why they're grouped that way. So you can see that, for example, having less education, which in the Lancet Commission was defined as education stopping at age 11 or 12, not going beyond that, accounted for up to 7% of worldwide dementia cases. So the larger the circle is, the bigger the impact that risk factor has on dementia risk. So you can see hearing loss is a pretty big circle, and then traumatic brain injury, fairly big, smoking as well. So this was taking worldwide prevalences for risk factors as far as as much as we could. And these are the numbers that we came up with. And the calculations also involved accounting for communality, so the fact that many of these risk factors tend to cluster together. So then we did some work that was published in Lancet Healthy Longevity to see what kind of interventions there were that could change the 9 individual risk factors. So this was work following the Lancet 2017 paper, so there were only 9 risk factors that we were considering at that point. So we did searches on PubMed to look for any individual interventions that were shown to be effective against these 9 risk factors, and then did some economic modeling to look at the costs and benefits of implementing these interventions. So the interventions had to successfully target any of the risk factors that I listed on the previous page. There needed to be evidence that the intervention improved risk or risk behavior, and they needed to be feasible in an adult population. So the calculations were from a societal perspective. So we looked at health, social, and family care costs, balanced that against the cost of the intervention itself. And then our colleagues at London School of Economics did some complicated modeling involving looking at annual incidence in people with the risk factor, reduction in incidence in people with the risk factor that was then successfully treated or controlled, and then comparing the two in terms of annual impact of dementia, and then eventually turning that into a cost per quality adjusted life year. So what did we find? I mean, I think what's most interesting is what we didn't find and couldn't model. So things such as education, for example. I mean, in the UK, we chose England as a sort of modeling site because that's where our sort of the Markov model for disease progression was based. And in the UK, it's already compulsory to go to be schooled until the age of 18. And there were no interventions that successfully made people be educated beyond that, although we know that sort of higher education is beneficial in terms of protecting against cognitive decline. So there were many such things that there just wasn't any evidence for, or it just wouldn't be feasible in an adult population. We didn't find any interventions that prevented depression, for example, and certainly the observational evidence indicates that the studies that have looked at depression and dementia have often grouped together people who have treated or untreated depression. So these were the interventions that we found, effective interventions, were hearing aids, antihypertensives, smoking cessation, and diabetes prevention. So again, diabetes treatment, the observational studies looking at diabetes and dementia often group together people with treated or untreated diabetes. And what we found that for 3 of these, so hearing aids, antihypertensives, and smoking cessation, if they were given to everyone that needed them, that potentially up to 8.5% of dementia cases could be prevented. So the prevalence would drop by 8.5%. But this is once they were fully implemented. So of course, giving time for it to have an impact on your subsequent development of dementia. And that it would actually result in almost £2 billion per year saving in terms of health, social, and unpaid care costs. But preventing diabetes wasn't worth it, not for dementia alone. Of course, preventing diabetes has many benefits beyond dementia. But we just narrowed our focus to just dementia for this. Otherwise, it would have been far too complicated. So that sounded very promising, but of course, that was theoretically, if everyone who had hypertension was given antihypertensives, and assuming that that had an impact on their hypertension, not everyone's will. Not everyone wants to do it. Not everyone will take their medication or go and see their doctor or have hearing aids or use hearing aids even if they're given a hearing aid. And not everyone will respond to the intervention the same. And then, of course, we didn't model the costs of promoting the interventions, about outreach, GPs contacting patients to get them to engage and so on. But the potential was there. So just to sort of circle back to this idea of how does this apply to everyone. So the diagram that I presented first was using worldwide prevalences and pooled relative risks based on meta-analyses. But what we were interested in is, well, does this apply across all countries, and are all risk factors equally important in different settings? So we used the 1066 data, which had data on risk factors for dementia, as well as subsequent dementia prevalence in 6 Latin American countries, in China and in India, and basically applied the same methodology but using the prevalences in these countries. So you can see that the education, for example, is already accounting for a larger proportion of dementia cases compared to the worldwide estimates. And then there are some differences. So we found that in Latin America, depression was a particularly important risk factor. Hearing loss was sort of similar. Hypertension is more, sort of seems to account for more cases compared to the worldwide estimates. So you can see that there's huge variation, indicating that actually, when we're thinking about dementia prevention, the country that you're in, the setting is important to look at, and we can't be, because we have to sort of be perhaps more tailored in which risk factors we consider most important and which risk factors we target. The other thing that I became aware of when doing these calculations was that most of the meta-analyses and systematic reviews were in primarily white participants. So these were mostly from America, Canada, Australia, Europe, and the UK, and most of the participants in these observational studies. So most of the cohort studies that we have, for example, have a very small percentage, if any, people from minority ethnic groups. Many of them have at least got diversity in terms of socioeconomic status, but ethnicity remains sort of underrepresented. So the UK has a sizable minority population, and there's evidence from, for example, the SABRE study at UCL looking at cardiovascular risk factors, where they found that for the same blood pressure in white compared to Black and South Asian participants, the same blood pressure would have a more detrimental effect on your risk of stroke in minority ethnic participants compared to the white population. So that's what they found, and so there may be the potential to do even more in minority ethnic groups in terms of prevention if the impact of these risk factors is greater. So I set about looking at this for a start by looking at primary care data as well as the UK Biobank, and finding that cardiovascular risk factors, particularly hypertension and diabetes, tend to be more common in the Black UK population and South Asians. And this seems to have an impact in terms of, at least in primary care records, an increase in incidence of dementia in the Black population. So there's potentially a greater susceptibility to dementia in minority ethnic groups. I've also looked at secondary mental health care data, finding that in the South Asian and the Black population, there's a younger age at diagnosis and more severe dementia when they are diagnosed based on MMSE scores, indicating, again, higher susceptibility so that they're getting it younger. And I sort of replicated these findings in primary care data as well. And then I've used the UK Biobank data as well as primary care data to see whether ethnicity modifies the impact of risk factors in for dementia. And I found in the UK Biobank there was no interaction effect, and this is a healthy volunteer population, whereas in primary care data I found that for some risk factors, particularly for hypertension and diabetes in the South Asian population, there seemed to be a greater impact of these risk factors on dementia risk in the South Asian and the Black population compared to the white population. So this could mean that there's a greater risk of dementia for each risk factor in the South Asian and the Black population compared to the white population. And then just some examples from the results, which are currently under review, so unfortunately not published yet. So this means potentially we could do more in minority ethnic groups, and we need to think not just about the country that we're looking at, but also groups within the country. So moving from risk factors now to actual studies, because of course the limitations with these observational studies is that it's not really trialing whether something can, if you manage a risk factor, whether it has an impact on your subsequent dementia risk. And I think out of these, I think the most exciting one was probably this SPRINT MIND trial, which was intensive hypertension control, so aiming for systolic blood pressure below 120 instead of the usual 140. And the trial was stopped early because it was so effective. I think the primary outcome was really stroke, but they also looked at cognition and found lower cognitive decline in people who had more intensive blood pressure control. Because the trial was stopped early, probably the results weren't significant in terms of differences in progression to dementia, but when you pooled mild cognitive impairment and dementia, the results were significant. So that was a very exciting trial. And then many of you must have heard of the FINGERS trial, which is a Finnish intervention. As always, I am impressed with their acronyms. This is a 2-year multi-domain study in people with cardiovascular risk factors. And it was quite an intensive study. So people had surveillance of their cardiovascular risk factors and management of that. They had, I think, up to 6 visits from a nurse. They had sort of coaching. And then a visit with a doctor. So quite a lot of involvement from professionals as well as sort of management of risk factors. And really, given all of that, the results were quite modest. So on a composite score, I'm trying to remember now, I think it was like sort of minus 0.2 on a Z-score, which was not, given how much intensive effort was involved, and the costs of that, it was quite modest in terms of preventing cognitive decline. And they didn't measure progression to dementia. And then the HATTIS trial, so this was an online coaching for management of vascular risk factors. So again, slightly lower costs in terms of, because it was online, for people to manage their sort of cardiovascular risk factors. This was not as expensive, and again, some sort of modest improvement or rather less decline in cognition. And interestingly, the FINGERS trial found that it was most effective in people with lowest educational levels, so potentially could be more effective in people who perhaps need it more. So that was interesting. And then there's been lots of trials that are not effective, such as exercise, cognitive training, or you get slightly better on whichever cognitive domain you are training on, but ultimately it doesn't help with your development of dementia and sort of vitamins, as Rob mentioned earlier as well. Currently there are trials of hearing aids, because as you can imagine with an observational study, so the observational studies that are looked at hearing aids find that people who use hearing aids have the same risk of dementia as people who don't have hearing loss. But of course, if you've got hearing loss and you're not using a hearing aid, is that because you're too cognitively impaired, or there are other factors about you that make you more likely to get dementia? So that's the difficulty with observational studies. Sort of ongoing trials of hearing aids, I think, will clarify this, whether it's helpful and practical in terms of preventing dementia. So as I've mentioned, the multi-domain interventions, although there was a lot of excitement when the trial results came out, it's labor and cost intensive. FINGERS have actually calculated that they estimate that there would be a sort of saving overall of just over $2,000 and increase in quality adjusted life years of 0.043. And as far as I can work out, they've they've done this sort of using Markov modeling. So on the assumption that if the differences in cognitive decline that they found, were continued, and if that then translated into subsequent less dementia in the intervention group, because as I said, they didn't sort of measure development of dementia. So I think that's what these results are based off. So I'm slightly skeptical, but anyway, this is what they've said, that it is cost effective, or actually cost saving. So far, we've been thinking about individual level interventions, people treating their hypertension or using hearing aids, but just put up this quote just to think about, is there potential to do more if we take a population-based approach to preventing dementia? And shouldn't we be doing this, given how much dementia costs not just the UK's economy, but globally, the world economy, and how much it costs families and people with dementia? Shouldn't we be doing more at a population level? And hopefully I'll make that argument, and also the argument that many of the risk factors that we would be targeting in order to prevent dementia are also targets for prevention of many other health conditions. So I think there's a good argument for doing them. So let's just think about sort of various policies that are in place that we don't really think of as policies. I think when people think, well, population-based approaches, some people may feel that their autonomy has been impinged upon, and everyone should be free to make decisions about their own health. And while I agree with that to a certain extent, but then if we think about the policies that are in place in the UK, for example, where that we don't question, we don't rebel against, or most people don't. So seatbelts, for example, been in place for decades. Many countries don't have compulsory seatbelts as a law, or if they do, they're not very well enforced. One study looking at whether people were wearing a seatbelt in a car crash found that traumatic brain injury was reduced, sort of more than halved. I think that's worth it. And if you think about the knock-on effect of less traumatic brain injury in terms of dementia prevention, I think that's worth it. There's been a lot of interest. I think every so often we get these news stories about contact sports and football, and whether people should be wearing helmets, should people be allowed to header the ball and so on. I think actually road traffic accidents are probably more of an interest than that in terms of the proportion of the population that's affected. Smoking, the smoking ban came into effect in 2007, and I think most of us have adjusted to that. There've been reasonably favourable attitudes towards it following surveys after it was implemented. And then in general practice, introducing cardiovascular risk management and incentives for doing that and reporting that. Education now compulsory up to age 18 in the UK, whereas previously it wasn't, and it sort of gradually increased over several years. And then we think about dietary factors, so labeling of foods with percentage fat or amount of salt, for example. What kind of impact could that have on hypertension and other cardiovascular risk factors? The Noise Pollution Act, I think most of us would agree that's a good thing. And in terms of hearing loss, I think that's probably quite a significant impact, as most hearing loss tends to be related to exposure to noise. And of course, health and safety rules at work mean that people who work around loud equipment, they have to have protective equipment. And all of these are policies that probably we don't think about day to day, but they could be having a big impact on our health. The Air Pollution Act, we'll have seen that the ULEZ is going to be expanded in London from August. Having already been expanded, I think it was last year or the year before, I remember, because we then were suddenly living in a ULEZ area and had to think about our car. And you can sort of see the trends in nitrous oxide, for example, in this graph. In London, last year there was or the year before, there was a paper about the fast food advertising ban and estimates that this had led to, I mean, really quite an astounding decrease in individuals with obesity. Again, I'm very skeptical about this result. I mean, it seemed like a robust paper, but yeah, so anyway, and then alcohol minimum pricing. I think Scotland's been doing a pilot with this, so various approaches that you could try. Of course, the considerations for policy level interventions are not insignificant. You know, there are costs associated with it. You know, you can't just change policies on a whim. It involves, you know, time for ministers to sit and debate and think and write things. Policy change, businesses have to adopt it and change their policies. There has to be public campaigns. You know, all of this costs money. However, you could potentially get benefit in terms of revenue from fines, and then of course dementia reduction, which is the whole point of this talk. You know, and the resultant reduction in costs that would bring about. And if we think about, you know, the smoking ban, for example, how many more people quit smoking or didn't take it up because of the smoking ban, compared to how many people would have chosen to go and you know, get nicotine chewing gum if left to their own devices. And then we think about the wider impact as well. There's impact on other health conditions. You know, smoking, you know, important for so many things: cancers, cardiovascular disease, stroke. You know, but of course you could have a lack of engagement. People rebel against these things, and then of course ministers are worried about how people will vote if they introduce these policies. So, in conclusion, I think. Overall, I think if I were to recommend one thing, it would be manage your blood pressure and don't smoke. I think, you know, that you couldn't argue that those are that there would be much negative impact of that. There's some positive findings of multi-domain interventions, but a lot of these are very labor and cost intensive. So, you know, I think we have to maybe think more widely about policy-based approaches and try to engage with policymakers around this. And that also, we need to be costing these up to see whether there'd be an overall cost effectiveness. That's it. Thank you very much for listening. I'm happy to take any questions.
So thank you very much. We've got time for a few questions. We've got some online. So it's well known that sleep deprivation beyond a certain level can cause short or medium cognitive impairment equivalent to that of alcohol intoxication. There is also evidence that long-term shift work has association with some other diseases, including cancer. And the person, Dr. Miles, said, I wonder if there's any association with chronic sleep deprivation and dementia.
Yeah, so there's been a lot of interest in sleep, and at the last Lancet Commission we debated whether to include sleep or not. I think there's the problem with sleep is that it seems that sleeping too much and sleeping too little both seem to have an impact, at least from the observational studies. So the magic number seems to be 7 hours, and then if you're sleeping less than that or more than that, like 9 hours, then that seems to increase your risk of dementia. Of course, it's difficult to tease out what's a sort of related to the prodrome of Alzheimer's, for example. So far we haven't found enough evidence to include it as an additional risk factor. But yes, try and have good quality sleep. I don't think that anyone would argue that that's going to cause you any harm.
Okay, and then Dr. Badani said, improving access to education in the countries outside Europe or North America levels a playing field, but education of itself, they are postulating, does not prevent dementia, it merely delays its manifestation, just as in European or American settings. Do you agree?
I think education, I think the effect of education is interesting, and we're trying to sort of do a study to work out why it is that it has an effect. It seems to be neuroprotective, so whether it's, you're somehow building up some sort of resilience in your brain, and this, so there's the idea of cognitive reserve, that you can then tolerate more neuropathology without developing dementia. I think that seems to be the thinking behind why education is good for you. But of course, I think with the caveat that, education quality is also important, and that's often not measured. And when it has been measured, it's shown that education quality is important. It's not just making sure people are in school. They have to be sort of actively learning and with good quality provision.
Thank you. Peter Garrett has a question.
Thanks for your talk. I noticed that you dismissed vitamin supplementation as a way of preventing dementia and cited Professor Howard's also comment on the failed vitamin E trial. But did you consider the role of elevated levels of homocysteine as a way of, as a factor in the onset and progression of dementia, and the quite easy way of bringing that down using a combination of B vitamins in any of your studies?
Yeah, we did debate it, and on the whole, it was felt that the evidence wasn't strong enough to include it. But it's certainly something we'll be looking at again in the next iteration. But certainly, if you're not deficient in any vitamins, then supplementation is not helpful in terms of cognitive decline.
Okay, 2 more questions, one at the back, and then we'll do one in the middle, and then we'll move on.
Hi, thank you. I'm over here, sorry. That was an excellent talk. Just a quick question about the traumatic brain injury findings, because obviously outside of childhood, there are sort of 2 spikes in when people have TBIs. Obviously, one early life, you might call them misadventures and accidents, and then when people fall, when they're older, a lot of elderly people fall and end up with moderate to severe TBI. So I'm curious to know how much of your risk is driven by those elderly people who are falling, and whether that's obviously then confounded by frailty. And then secondly, if there is any relationship between late life TBI and dementia, should we be following up older people who fall and have moderate to severe TBIs much more closely than we are at the moment?
Yeah, I take your point definitely about the sort of confounding effect of sort of people falling later in life, and that I think I agree. I think that perhaps that should be an indication for sort of monitoring more closely. I think the TBI evidence is very mixed in terms of sort of covering age ranges. So it's not just the older people who are falling, and the TBI tends to be from road traffic accidents as well as sort of sport-related injury, for example. So in younger people as well, and there was quite strong evidence that any amount of traumatic brain injury, mild, moderate, severe, all of it is associated with dementia, and in quite a convincing sort of dose-related way. So, but yes, absolutely could be. For older people, there's definitely the issues around frailty, and that needs to be borne in mind.
One more question just in the middle, and then.
Thanks for the really good talk. The hearing loss data is obviously really interesting. Did you look at visual loss? Because presumably kind of makes a bit of neurobiological sense that the bits of the brain that are affected in dementia are also involved in vision processing, confluence of sort of hypertension, diabetes risk factors affecting vision, and it might be relevant across different cultures where availability of visual screening is perhaps less.
Yes, absolutely. I think visual loss has particularly emerged in the last few years as highly relevant, and we're, as I said, we'll be doing another Lancet commission, and are very likely to include visual loss because it is a very, very strongly associated.
Lovely. I've just got one more question while Professor Clare starts making her way to the podium, which is, you mentioned about hearing loss and hearing aids and how some people don't have them and don't use them, as is the case with my family. Do you think there's a personality or kind of behavioural element or predisposition to dementia that has an effect that is kind of more long-standing? Just thinking in line of our kind of conference theme about how different people see the world differently and react to it differently. Do you think there's a predisposition to that for some people?
Related to hearing loss, or?
No, related to kind of the way they approach illness, the way they approach life. I have hearing loss, I don't want to use anything. That kind of approach that might predispose some sectors of the population to dementia or other illnesses.
Yeah, I think it's possible. I think there's an increase in interest in psychological factors that are related to dementia as well, but also I do wonder whether education and whether it's that sense of, first of all, being more aware of health-related matters that is having the impact in terms of dementia risk, or even just a sense of, it sounds very very American, but like that sense of sort of self-worth, that you're sort of worth preserving in a way that also has an impact. And I don't know whether it's, education per se that's having that impact, or whether there's, personality-related factors that that perhaps are, maybe we need to be looking at sort of early life, deprivation, for example, because that's also another strong associated factor in terms of its impact.
Lovely. Thank you very much. Thank you.